Gordon Smith, the state's director of opioid response in Governor Mills' office. I really appreciate all of you being with us today. We had almost 300 people register for the webinar today, and we are so delighted to have guests with us from Iceland, from Planet Youth, who will be talking about really the very significant and well-known prevention program in Iceland that loosely we call the Icelandic Prevention Model. And we're so grateful for Nicole Barreiro from Maine, who has been in Iceland and made this program possible. And Nicole, I'm going to introduce in a minute, and she's going to actually introduce our guests. I want to make a couple announcements. We will be doing a program, of course, every month, the first Friday between now and the July 16th summit, where we will be in Bangor for the Governor Mills 8th and final opioid response summit. We expect well over 1,000 people. The announcement went out to save the date, and the call for presentations. If you'd like to put in a proposal to do a breakout session, all of you presumably received that, I think, yesterday. We're very excited about the summit this year. We'll be looking back on the 7.5 years of experience that we'd have by that time, but also looking ahead to what's going to follow and what needs to continue. In March, we'll do a program on all things recovery that Mike Freisinger will be the primary presenter from the Office of Behavioral Health, recovery coaches, recovery centers, recovery residences, recovery-friendly work sites, all of our projects focused on recovery. Today, as you know, we're focusing on prevention. In April, we're going to have a program from the Song for Charlie people out of California. I've talked about that before. In June, we're going to have a program featuring an announcement about the Black poster program that would bring him back to Lewiston in September. And then, as I say, July 16th, we'll be in Bangor for the summit. Today, there's a news release coming out from the governor's office that's going to talk about our experience in 2025 with respect to both fatal and non-fatal overdoses. I want to let the governor make those announcements and not let the cat out of the bag here today. This morning, I will tell you that obviously we probably wouldn't be doing an announcement if the experience was not quite very favorable. We continued to have a good experience, although I want to acknowledge that it's not uniform across the state. There's still some pockets in a couple cities where there's been no improvement, and we've still got a lot of work to do. But watch for that press release today. I want to thank again Nicole. I want to thank Richard Freund from OBH and Lorena from La Liberty from ADAPT for making these programs possible, making it very easy for me. And finally, thanks to all of you for participating. Please put any questions that you have in the question and answer section, not the chat, but the question and answer section, and we will get to all the questions. If we don't get to them at the end of the program, or we don't answer them in writing today, then we will put them on the website and have them available to you, as we always do. I think that's all the announcements that I have. Again, I'm so appreciative of our international guests today, and I'm going to turn this over to Nicole Barreiro, who's going to talk very briefly about her fellowship in Iceland, because if Nicole hadn't gone to Iceland and had this opportunity, we wouldn't have been probably had this wonderful connection with the Planet Youth leadership and had this program for you today. So, Nicole, I'm going to hand it over to you, and I'll come back in and just thank everybody after we've had the presentations.
Thank you, Gordon, and I will keep this brief because we have real experts to hear from, but I just wanted to mention that my efforts with the Fulbright project started almost 2 years ago with correspondence between me and Helgi Gunnlaugsson, who is a professor of sociology focusing on crime and drugs and related issues, at the University of Iceland, which would end up being my sponsor for this program. So I'd like to say a thank you to them, to the Fulbright program in general, the Ministry of Foreign Affairs, and Fulbright Iceland for making this possible. So in 2023, I attended a substance use conference in Leuven, Belgium, and after a specific conversation, I started researching problematic substance use and prevention in Nordic countries. I read Upstream by Dan Heath, which is a book that I recommend. I read Prevention Science Research by Zili Sloboda, and ultimately I centered my project on Iceland. This project earned the Scholar Award from Fulbright, and I traveled extensively over the fall semester and met with many people, including the amazing Planet Youth group in Reykjavik. I strongly believe in drug prevention. I think partly because of ineffective programs such as DARE and Just Say No, prevention can be diminished at times or considered vague or unmeasurable. There's also limited funding issues, driven in part by policymakers who are impatient for quick results. So there's no building that I can point to as a result of my funding. Prevention is much more than saying no. It's more than information sharing. It's a long-term investment. That's how I see it. It requires upstream thinking, which is the concept that's discussed in Dan Heath's book. And that means thinking about systems rather than symptoms. To build a culture of prevention, this is all data-driven. It's supported by theory, rigorous research, and a cross-disciplinary approach. It translates research into real-world practice, and it takes into account an understanding that learning and developmental shape what is going to go on with youth at different ages. It even includes neuroscience and how the brain can make decisions. The power of community and cultural factors are really important as well. And with that, I would like to introduce our esteemed guest. We have Dr. Paul Rickardsson, Dr. Ingeborg Eva Thorisdottir, and Mr. Nicolas Barreiro. Dr. Rickardsson is the Chief Executive Officer. Dr. Thorisdottir is the Chief Analytics and Advisory Officer, and Nicolas Barreiro is the Partner Relations Manager at Planet Youth. So I will turn it over to you, Paul. Thank you very much.
Thank you very much, Nicole, for this introduction. And I'm very happy to be here to give you a little bit of an insight into the Icelandic Prevention Model and what we do at Planet Youth. So I want to address a couple of things today. I want to give you a little bit, Nicole started the discussion, but I want to give you a little insight into what we have been experiencing for the past years as we work in primary prevention. There is a paradigm shift emerging in the way we see and think about prevention. I want to give you an insight into the Icelandic Prevention Model, what it is, what it isn't, and how it has developed. I want to give you an insight into what underlies the implementation of it and adaptations in other contexts than Iceland. Give you a little bit of an insight into Planet Youth, who we are and how we work with the Icelandic Prevention Model and our projects and current partners. And then what results we are seeing both in the US and with other partners that we are working with in around the world. Now, paradigms. So I will describe our projects a bit later on, but we have more than 50 projects in more than 20 countries. And we can see there is an emerging paradigm shift that is needed within primary prevention. So we are shifting towards an upstream paradigm. And Nicole mentioned the book Upstream by Dan Heath. I recommend that book as well. It's a really good insight into what this way of thinking is. But what it means for primary prevention, it means that we are going away from looking at prevention as a free good. It's not something you do on a voluntary basis. It's not something you do after 4 o'clock on a Friday. It's something that costs money to implement. It costs resources to get that quality that you need in prevention. Prevention is not a project. It's not something you implement starting in January and then you finish in December and then you evaluate. No, it's a process. It's a practical process that needs to go on throughout the years. Soft money funded, we all know that, is funded by grants or donations, but there is a need to make prevention hard money funded, make it a part of how we address these problems in communities and society. It's not a cost, it's an investment. I'll come back to that later on, but seeing something as a cost means you are paying for something one-off, whereas an investment has returns. And that is what prevention is. It's not an academic exercise of planning, implementing, and evaluating, writing reports and scientific articles. It's a learning experience. It's something you develop, design, you test different methods of prevention, you monitor through quality data, and then you use that data to learn what works and does not work over time. It's not focused on individuals. It's not focused on telling the individuals you should just say no, but it's focused on the community. Community prevention starts and ends in the community, and it's the community that needs to carry out the interventions and actions that are needed to practice prevention. And we are also seeing that it has been politically invisible because prevention, hey, you're investing in something that didn't happen. But it's emerging as a political platform as well, because we are, particularly when you're looking at youth, you are thinking about the next generation. You are encouraging and making the next generation better off. So we are seeing this paradigm change in primary prevention. I will get back to some of these issues later on. Now, the Icelandic Prevention Model, we often start with this picture here. And this tells a lot of stories, this picture. It tells us that Iceland, when it comes to substance use, and there are other variables that we monitor, but this is just one example. When it comes to substance use, alcohol, cannabis, nicotine, we have in Iceland, we have made tremendous progress in these elements in the lives of youth. In 1998, we were I think we had the world record in the consumption of alcohol and tobacco, whereas today we have the world record in how little our young consume substances. That's one story it tells. It also tells a story of a monitoring system. Like when new challenges emerge, like vaping, nicotine pouches, this system captures those challenges through data, makes us aware of there is a challenge, and then monitors the activities that are implemented to tackle these challenges, as you can see with the nicotine pouches and the vaping that emerged in 2015-16. It also tells a story of, like today, there are 6% of the kids that have been drunk for the past 30 days. But that means there are 94% of the kids that haven't touched alcohol. So looking at just the ones that do tells another story of the kids that actually don't and have elected a substance-free lifestyle. When you look under the hood of the Icelandic Prevention Model, it's based on, it's nothing as such new in that particular model. It's based on sociological theories since the 1970s, deviation theory, theories about the impact of the environment on behavior. So when we look at the Icelandic Prevention Model and the theoretical grounding of it, it stresses that the behavior of kids are shaped by the environment. Rational choice when you're 15, I got a 15-year-old son, and he does not make rational choices some of the time, but his behavior is governed by the environment, is governed by the family, by the school, which occupies a lot of their time, by the community, by their friends, and by the free time, what they do in their free time. And these four factors are in the Icelandic Prevention Model. They're labeled risk and protective factors. And these are the factors that the model focuses on impacting or affecting. So we're not focusing on the individual, we are focusing on strengthening the protective factors and minimizing the risk factors in the lives of kids. And again, these protective factors, they have been present for a very long time in research and in theory. And there are some natural laws there that we so to speak, that we observe, like time spent with family is a protective factor. Participation in organized leisure time activities, structured organized leisure time activities is a protective factor. Feeling safe at school and having grown-ups at school that care about you is a protective factor. So there are some factors that you can focus on and are pretty much universal. I get back to that also, what the data shows us when it comes to that. So that's one element of this, kind of the underlying sociological theory. When we talk about implementation of the Icelandic Prevention Model, there are some guiding principles we have to observe. One is that this particular prevention approach is designed for the social environment. Again, it's not about individuals, it's about enhancing the social environment around the kids, strengthening the protective factors, minimizing the risk factors. It's about community and a community action. And this one here says public schools, but it basically schools, they can be private or public, but it's about embracing the schools as this natural hub of the social environment in which the kids travel in. And the community around that hub is the one where we anchor the model, the activities that the model leads to. And then it's about the empowering and engaging those community members to act. And that is done to a large extent through data. And not just any data, but this high quality, accessible, understandable data that is shared with the community about the kids. I'll get back to that later, but that is a critical element of the model. And then it's about integrating the researchers, policymakers, practitioners, other stakeholders in the community into this coalition. And the coalition is kind of this nucleus, the unit that kind of carries the prevention into the community and enable them to address and solve a complex real world problem. And finally, match the scope of the solution to the scope of the problem. This is not something you solve by an intervention that takes 9 months or 10 months. It's a complex, thorny problem to increase youth well-being and reduce the risk factors and to enable kids to make healthier choices. And that just takes time. And that is something we need to accept. So based on these guiding principles, we have the 10 implementation steps of the Icelandic Prevention Model. This is kind of the engine, the process by which the Icelandic model is adapted and implemented in communities. The first 3 steps are basically preparation. It's about building that coalition that needs to be built to carry out the prevention activities. It's about resources, identifying funding, developing capacity, and it's about preparing the data collection in the community. The next steps, 4, 5, and 6 are about the data collection. I mentioned that as a critical element of the model, and it is. So there is the questionnaire that is being used in implementing and adapting the model is, again, nothing that is developed by someone in Iceland. It's an amalgam of different questions and different scales, but it addresses the core of the model, which are the risk and protective factors, which are the consumption variables, well-being variables, and it also includes, it has to include new challenges like screen time and mental health. But the data collection, that takes place usually in schools. The data collection, the data is then processed and cleaned and analyzed and put into reports that are made available to the community within a very short time. We at Planet Youth, we return the data in reports within 8 weeks, and we do population surveys. So we go after a response rate of 85% in each community of the 14, 15-year-olds. Why population surveys? It just makes all communication and dissemination so much simpler. You don't have to worry about sample population statistics and significance levels. This is the voice of all the kids right here, right now, that is telling us about their lives and well-being, their consumption, and their risk and protective factors. We also stress that the reports need to be simple. There's a lot of graphics, a lot of visuals, a lot of illustrations, because they are going to be disseminated to a community with people that might not be particularly interested in statistics or tables or numbers. So we need to make them accessible and understandable to the community as a whole. Now, after that is done and being disseminated, there is 7 and 8, which is basically the action definition part of the model, because data without action is just data. So the data needs to be put to work. You need to, the community needs to understand what we should be addressing, taking that knowledge and then defining and designing actions based on that knowledge. Now, actions differ. You know, what we did in Iceland or are doing in Iceland does not necessarily work in Kentucky or Maine or South Africa or New Zealand. So the definitions of actions and upstream actions and interventions is always the role of the partner. They understand the local context. They understand how the cultural sensitivity or the cultural factors that are at play. So it's always the partner that defines and then implements those actions. Planet Youth, and I come back to that later, we can advise and we can point out best practices and share knowledge of what is being done in similar societies around the world. It is always the responsibility of the partner to design, implement, and run the upstream actions that are on the ground. Same with the policy and practice alignment. You know, policies differ, and we are talking about prevention policies, about supply access policies. So that's always something the partner needs to address in the coalitions that they have formed. Now, after that, step 9 is basically to immerse the kids in what has been decided to do, you know, whatever that might be, strengthening the parental social capital, strengthening the ties between the school and the parents, building structured leisure time activities and motivating the kids to participate in them. Whatever, I think we have like an overview of like hundreds of different activities that can be done, but that's the activities that the kids are then immersed in over time. And then step 10, you will repeat this over time. And I will get back to that later on. Then you repeat the process. You measure again, not the same kids, but you measure again in 1 or 2 years. You measure the kids that are 14, 15-year-old at that time and have been subjected to the upstream activities and actions that have been implemented. So we're not measuring the kids, we are measuring the impact of changes in the social environment on the kids' behavior and choices. And then we do that again and again and again and again, so we can see how the social environment is changing in response to the actions we are implementing. Now, who are we in Planet Youth? Now, Planet Youth has a longer history. So it all started here in Iceland in the beginning of the 90s, where there was something called Rannsóknarstofnun uppeldis og menntamála. It was abbreviated RUM, which is interesting in this context. But it started surveying the kids here in Iceland based on surveys that were actually carried out in the US at the time. These surveys got taken over by ICSGRA, Icelandic Center for Research and Analysis, in the late 1990s. That carried it forward, developed the model in conjunction with other stakeholders. They launched Youth in Europe, which kind of the precursor of what we are doing today. It was only data collection, and then as ICSGRA, and it was more of an academic exercise back then. It was linked to university. Then did the reports and handed the reports over to the partners with the expectation that something would happen. But as often with you hand a report over and expect the world to change, the world did not change. So we could see that the reports were presented, and then nothing basically happened. So that changed when we founded Planet Youth in the 2020, where we could see the need to, yes, have the data and the reports, but also to support the implementations, designing actions, and then following through with these actions to change the social environment around the kids. Now, Planet Youth as an organization, we define ourselves as a social economy organization. We are owned by the employees. We have no investors. We don't pay dividends, don't carry any debt, and we sustain our operations by charging for our services. And it was a long discussion in the beginning if we should be not dependent on governmental funds or research grants or donations, but we elected to go this way, and it has proven enabling for the rapid expansion we have experienced for the past 5 years. And we want to empower communities to create this healthier environment for youth. We don't do it ourselves. It's through the communities that we work with that this happens. And we just want to reach as many kids as possible. That's basically what we are all about. And we define ourselves as a upstream prevention solution architects. So we help communities to strengthen and implement that infrastructure that is necessary to carry out these upstream prevention actions. We have the Planet Youth Guidance Program. I'll get back to that a little bit later, what that is. That is what we started with, but we also have services within advising national, state, and local governments in upstream prevention activities, assessing the gap between what is being done today and what needs to be done if you want to do an upstream prevention strategy, data and analytics and insights carried out in isolation. We have the Planet Youth Academy, planetyouthacademy.org, and if you go in there are some short courses and educational material about upstream prevention. And we arrange conferences and learning journeys. There's a lot of people who want to come to Iceland to see and study the Icelandic Prevention Model, and we help them with that as well. Now, the guidance program as such, like I said, this is not, well, it's called a program, but it's not really a program. It's a 5-year journey with our partner, which is based on starting with a lot of knowledge transfer or knowledge development to the coalitions of the partner. The data collection happened, the first data collection happens in year 1, so that kind of established the baseline for the process. And then the actions and the policy alignment happens in year 1 as well. Year 2 is an implementation year, an evaluation year, where you implement, you learn, you study the impact of the actions that you are implementing. You measure again in year 3, again, not the same kids, but the kids that have been subjected to the actions you have implemented. Again, based on that, you align, you learn, and then you implement and evaluate. And then in year 5, you measure again the kids that have been through these actions and interventions, again, to see the impact of those actions on the social environment. We usually say in 5 years, you will our partners, and I'll get back to the results later on, but our partners will see some process results, breakdown of silos. We have observed that when you suddenly have one version of the truth, what the kids are doing, thinking, and feeling, there will be some impact results as well, where you can see the impacts of the strengthening of the protective factors. Outcome results, yes, there might be some, and we have observed some with our partners, but usually those also take a longer time to materialize. After 5 years, we usually want to leave. So we often continue, yes, but often our role just changes into more of a helping role, because our aim is to not to deliver fish, but fishing rods. I know it's a cliche, but that's what we try to do. We want to build the capacity and competence within the community to run this process on their own, kind of the ultimate aim that we have. These are the faces of Planet Youth team. Here we are not many. We are partner based, and our partners are many, so that's where we have the real power of the organization. But we have a lot of different capacities and competencies, project managers and data analysts and knowledge specialists, and we have ambassadors around the world that help us, help our partners get in touch with us. We are, in only 5 years, we feel we have established quite a global presence. We have projects all over the world, and we travel a lot. My wife says I'm in good shape, but it's the shape of an airline seat. But we do visit a lot of the projects over time, and we have established some legal entities in different countries. The latest one now in Uganda, which is starting this journey with us this year. Just an example or overview of our partners around the world. We have quite a few in the United States and Canada, and also, of course, in Europe, where we have grown quite a bit in the last years. One thing about sustainability that is emerging, again, we are doing this more on a practical level. You know, there are academic articles that address sustainability and how you keep processes running in communities, but we find in the projects that we have been running and been in with our partners, and also the ones that have stopped, that there are some criteria and dimensions that need to be in place if you want to run and operate an upstream prevention process over time. And one is, of course, funding availability. And in the countries that we are in, you know, there are large variations between funding environments. In the US, the funding environment is often based on grants. Both in the US and Canada, we also have philanthropic donations and donors that fund the projects. It's good in the sense that you have a very specified funding line for the project. The cons are obviously that the funding runs out at a certain time, and often you can't get money for the same project twice. So you're up against redefining and reinventing the project. So in other countries, like in the European countries and to an extent in Canada, we have funding lines that go to the government, either the local government, state government, or national government, and enables funding over time, of a longer period of time, for these types of projects. There's also a need for a mental model change, going from the individual focused definition of prevention to a community focused definition of prevention. There is a need to look beyond what's happening right here, right now, and look into the future, and then look upstream at what we can do today to make sure this does not happen in the future. We need to embed the process in the processes that we have to work with. We need to keep the project experience in the projects. We see quite a bit of turnover in these types of projects, and with each person that leaves the project, valuable knowledge and experience leaves with them, and that needs to be, you know, we need to address that as well. And then it's also a question of political priorities. Now, politics often change every 4 years, and even if we're doing something good, if a new political power comes into play that thinks what the other guys were doing was no good, then that will change how we are doing prevention. We've seen that in quite a few countries in the past 5 years, particularly in Latin America. Now, a couple of emerging results I want to share with you. One is from Franklin County in the Kentucky, and I've only taken the alcohol results, and there's a lot of other results that and these particular examples have demonstrated, but we can see, and they've been doing this for quite for 5-6 years, and it's quite an impressive result in my mind, what they have achieved for the 7th and 8th grade up to 12th grade when it comes to substances. And they have implemented a variety of different actions. They have a parental cafe, they call it, but it's basically a tool to strengthen the social capital of the parental group and link them to the school. They have what they call the Yes Card, and if you Google that, you will see their homepage, which is basically a tool to increase the motivation and means of the kids to participate in structured leisure time activities, which is a protective factor. And through those and other activities, you know, they have achieved these results, which they then document and monitor over time. Vilnius in Lithuania, one of the Baltic states, they've also been doing this for a number of years. With the last 3 data collections are beginning to show also a reduction in their consumption of alcohol, these kids, and in other variables. And they have implemented a variety of interventions and actions within their schools, for example, that are generating these results. I have 2 examples from Spain. So Amposta, again, okay, I see some of this is in Spanish. I hope that's okay. But they can see in the girls and boys, they can see how the activities they have implemented has impacted their behavior when it comes to alcohol consumption. Again, after 3 data collections, the first one is 2019. Then we had COVID, which threw a spanner in the works in many of these projects. And then they started measuring again in 2022 and then again in 24. Again, we see some very substantial impact of the way that they are driving this. Similar story from Lleida, also in Spain, where we can see an interesting results in outcome results of this. There are some others when we look at the risk and protective factors. One from South Africa. This is the Western Cape in South Africa. This particular data is from George, but just to say, this is probably the most complex statistical analysis and statistical presentation that we have in the reports. This is just to show the correlation between behavior to demonstrate the impact of the risk and protective factors. Now, this one demonstrates the impact on behavior, having friends that get drunk, smoke hookah pipe, which is something that they are focused on in South Africa, or take daga. And again, if we say if you've been drunk for the past 30 days, the kids that answer, if you have friends that have been drunk for the 30 days, then 40% of the kids that have those friends, they answer they also have been drunk for the past 30 days. Kids that answer they do not have friends that get drunk and smoke these pipes, only 12% of them have been drunk for the past 30 days. So just to illustrate that having friends that exhibit a certain behavior affects the behavior of you as a kid. Similar fact from Ireland, Galway, Roscommon and Mayo, they published this research that just demonstrate the universality of the risk and protective factors. That, if kids that have parents who disapprove of drinking, they drink less. If you have friends who drink, then you also drink less. You also drink less. If you have youth with poor mental health, they drink more. If you get alcohol from your parents, you drink more. If you, as a kid, get alcohol from your friends, you drink more. Youth with less school engagement, they drink more as well. So again, risk and protective factors, we see these results in a lot of countries. So we also see, and they demonstrate the universal applicability of strengthening protective factors and addressing the risk factors, minimizing the risk factors in the social environment of the kids. And that's basically what this Icelandic Prevention Model and the Planet Youth Guidance Program is all about. How you do it, how you strengthen the protective factors and minimize the risk factors is always at the discretion of the community in question. Another, Chile. So we worked in Chile for 6 years, and we worked with 2 different governments to set up a model or a practice that is basically modeled after the Icelandic Prevention Model. And if you look at their plan now for 24 to 2030, their prevention policy for this country of 18 million is modeled and after the Icelandic Prevention Model. That prevention is more effective than treatment. Use of data, they measure the kids every second year in these 340 something municipalities. Focus on driving change on a community level. And they also acknowledge that we need to work across ministries, across institutions to drive prevention throughout the country. Now, just to wrap up, this is something that is kind of close to my heart, I think, because there's a lot of things that are important, but I think if we really want to change something, we should always go after the money. And the way we measure money and benefits of spending money is something that guides decision on all levels, both in the private sector and in the public sector. And we have all of these surveys that show us, and I've just taken some of them here, that show us that upstream prevention, investing in upstream prevention creates value. It's 12 to 18-fold return on every dollar that is invested in upstream prevention. And then we can ask, so why aren't we investing more in upstream prevention? Because all of these surveys, all of this research show that if we do this, then we need less treatment, there is less crime, and there is better health, which leads to lower secondary and tertiary treatment costs, which leads to lower police and security costs, leads to lower cost of health systems and increased capacity in these systems as well. And I think in my mind, we need to look at and change the way we account for these benefits and how they materialize and who benefits from them, and make them visible in our systems so we can actually track and see where these benefits they emerge. Because if we do that, then the logic of putting money, resources in the public sector, for example, into projects and initiatives that actually create value, then that will be strengthened. And finally, or not quite finally, but almost, in our heads in Planet Youth, it's not just about the kids, because if you think about it, if you implement upstream actions and you will get happier, healthier children, then these happy, healthy children will become happy, healthy adults. And then at some stage, you will have a happier, healthier society. And then you, of course, ask, is Iceland the happiest, healthiest society on earth? And the answer is no. For some reason, Finland holds that title. I have to look into the research, but we are close to it. I think we're in third place, actually. And finally, just wanted to make you aware of this conference in May. If you want to learn more about the Icelandic Prevention Model, if you want to hear our partners from around the world come and talk about how they have implemented this type of upstream prevention, also from North America, or go on study tours to see how the model is being enacted in Icelandic society, then this would be the place to do it. It's in May, so the weather is maybe good. No, it's not. Iceland's got 2 seasons. It's winter and disappointment. And May is actually the start of the disappointing season. But it can be good. So thank you very much. And I hope you learned something, a little bit more about the Icelandic Prevention Model. I'm looking forward to your questions.
Thank you very, very much, Paul. It was an excellent presentation. We've got 15 minutes available for questions. There's been one put in the question, and I've got some questions too, and others may as well. I think I can articulate Dr. Fowling-Mock's question. She was questioning the use in your slides of the term drunk, believing that that was the consumption of any alcohol, as opposed to our colloquialism in this country would be getting drunk, consuming alcohol to the point of being inebriated. Do you agree with that characterization?
Yes, maybe Inga can answer that and how we structure and formulate the questions, because they do vary between contexts, because it's all culturally based. So Inga.
Yeah, so the graphs that Pat was showing, that is equivalent to the US colloquial sense of getting drunk. Of course, the question is phrased differently, but then we also measure any alcohol consumption with a different question.
Yeah. My question, and thank you to you and Nicolas for joining us for this question and answer period. And it's probably an unfair question, Paul, because it requires you to. It's like picking your favorite child, but I'm interested in you're doing projects all over the world now, and many in this in the United States. Is we don't have the ability, of course, to do a deep dive into every one of your projects. So if I were to go across this country and find a project that you've got, where would you send me? Where do they really? Wherever you've cited one county, I think in Kentucky, but give me a couple places that we might do a deep dive and say, boy, they've really got this figured out.
Yeah, I would say we have 3 projects in Kentucky. I only addressed one of them. I think those projects are actually doing a very good job in the stage that they are in. So I think that's something I would have a look at. But the projects are really different. And you say choosing my favorite child. We also have we have a project in Washington State that is close to my heart, at least, and we work with the tribal communities in Washington State, where we focus on at the stage that we are in. It's more of a focus on adapting the methodology, adapting the data collection, adapting the way we communicate to that particular context, and that requires us also to modify and to rethink some of the assumptions that we have going from our Western culture into that tribal context. So I think that would be or will be a really interesting project as we go along. But all the projects they're at different stages. Some have been going it for 1 year, 2 year, 3 years, or like Frankfurt in Kentucky for almost 6 years. But they all follow the same process. It's all the 10 steps. They're all observing the guiding principles, but they are doing a lot of different things. So it's a different activities, different interventions that are being carried out in these communities from one community to another. So it's difficult to kind of point towards one that is kind of doing everything right, because everybody is doing everything right, but it's just different things that they are doing.
Okay, I'm going to read a question from our friend Liz Blackwell-Moore. Liz sat with me on the Maine Recovery Council that has half the settlement money. Is one of our more visible and active prevention specialists in the state. She runs Cumberland County Public Health Division now. But so I'm just going to read her question because there's a lot to it. And thank you, Liz, for participating and for your question. She says, I'm wondering if you can speak to specific policies that you think have had the most impact on youth substance use. I have found that when the Icelandic model gets talked about here, it's often talked about as only the after-school component. Yet Iceland has universal health care, subsidized health care, monthly child payments, and living wages. How much do you feel like those have contributed to the success of prevention efforts in Iceland? How would you suggest we advocate for some of those policy changes that help bolster all the other efforts to address risk and protective factors at the family and the school level? There's a lot to unpack here, but why don't you give it a try, Paul?
That's a good question. But then I would say back in 1998, which is where I grew up, and I remember this time vividly, we also had free healthcare and we had free education, and we couldn't buy alcohol until we were 20 years old, and there were ban on alcohol ads. That was also the case back in 1998. The access to alcohol has that had an impact. Well, when I was growing up, it just wasn't a factor. You could always get alcohol, you could always get tobacco, you could always get cannabis. So healthcare, back then we had, I think, 11 treatment centers for alcohol. Now we have one. Well, we have several others, but the need for treatment centers has gone down drastically. But I think, yes, of course it plays a role, but would we have achieved the same results without implementing the Icelandic Prevention Model over time, focusing on risk and protective factors? No, we couldn't have. And if you compare the changes in Iceland compared to the rest of Scandinavia or other island nations, or the general reduction in risk behavior in Europe, then the Icelandic numbers just show a way faster and more rapid decline in risky behavior and alcohol consumption, substance consumption, than in other countries. Also the ones with free healthcare and free education and all of that.
I think that's a good response. I appreciate that. Inga, you want to add anything to that?
Yeah, I think this is a good response as well. I mean, when I'm growing up, it's at the start of the Icelandic Prevention Model. It's really at the start when I'm at the top of the consumption levels in the curve, my generation or my cohort, and it was very normalized. So of course, as Pat was saying, we have a lot of support in the policies that have been implemented. That being said, we also have politicians that come now and again and want to increase access to alcohol, knowing how that might impact youth, and not just youth directly that they will have more access, but their families as well. So this comes up again and again. So when we're thinking more liberal, we want people to be able to make choices. So I think definitely there was a lot of change in what parents allowed to begin with, but that went across the sector. So you had school supporting, you had the community supporting, you had the local law enforcement was supporting, and the welfare systems as well, or the social support systems. So I think that was kind of where we started to shift this curve, but we had very favorable grounds as well. But that being said, in a lot of the communities that we work with, it's not necessarily that there have been huge changes in policies, but they have been able to see a reduction in substance use in their communities. So I definitely think it is an alignment of multiple things, but focusing on equality is important, because I saw there's another question on equality as well.
Yes, yeah, there is. I wanted to pick up on something that you said and ask a follow-up question. You commented that there are public policymakers, politicians, if you will, that push more alcohol. Is that because of tax revenue? Is that because of the ability? I mean, in this country, I mean, tobacco and alcohol and now cannabis. There's always a delicate balance there between, the states have become very dependent upon revenue generated by high taxes on these substances.
Mm-hmm.
So, I mean, there are attempts sometimes to repeal the recreational legalization of cannabis. Well, now that would create a bit of a budget hole. So I'm just wondering why else would, if it's not for revenue purposes, why else would people be pushing alcohol?
I think it's both. I think it's revenue, and then also having just more options that you can get it sent home. And it definitely changed. I will say the COVID pandemic and home deliveries changed this very much. And we have had prevention specialists in Iceland that are actually reporting themselves to the police because they're able to buy alcohol illegally, because it's in a gray area, as very often is with the market. The market comes in and there isn't really a place, because when the legislation was written, there were no maybe online stores that delivered alcohol. And the same happened with electronic cigarettes. When they came into the market, there was just a gap in the legislation, the same that we're seeing with nicotine pouches. So public health professionals and policymakers are constantly trying to beat the market, and we seem to be very often far behind when it comes with placing these new products into our existing frameworks.
I guess I should go to this question from my sister just for family purposes. Let me see what she has asked. Can you read that question? Now something's popped up. Here it is from Edie Smith. Can you share if there's an average cost for the prevention programs? Great question, Edie. How much funding typically has to be raised for a successful program? We haven't talked about that at all. That'd be a great question to answer.
That's a really good question. So we try to run Planet Youth on as close to a break-even point as possible. So we define the fees for us, based on the scale and scope and complexity of the project. So the minimum fee now in 2026 for a project is 49,850 euros, which is about $57,000, $60,000.
Yep.
And that is a project that we define as reaches 50,000 people and has a certain number of schools and a certain number of kids that we survey. But our fee is only one part of the equation. I mean, for a local community, that's often the price of a traffic light. I mean, that's one thing. There is also the costs required. And remember, like I was talking about in the beginning, prevention is not free. There has to be people running the project. There has to be a project manager. There has to be a coalition. There has to be paid protected time to actually implement the interventions and the actions necessary to change the social environment. So all of those costs have to be factored into the project as well. And as the project grows in scale and scope, we're talking like in Chile, 18 million people on a national level, to at the Western Cape with 1.5 million people, and then those types of projects are just necessarily more complex and more resource intensive if you go that route than a project in the northern Canada where they have 26 kids we survey. So it just depends on the size of the project. Our fees are pretty fixed when it comes to that.
Thanks. I want to get this last. Go ahead, Ingrid.
Can I add maybe a little bit here, because all of the communities that we are working with and have worked with have built in very sophisticated prevention activities. So we are never asking anyone when we start working with them that we're starting again. Mm-hmm. The plan is not to reinvent the wheel, but what is often missing is this shared system that connects the efforts. So it's often about thinking about the resources that we're already putting towards prevention. How can we better use them? How can we maybe use some of the intense labor that we need, or some of the materials that we need? How can we work with this together? So it's very often about also, it's the systems framework, it's the systems thinking, instead of doing this new activity, this new policy, and everything is going to change. It's about the big picture.
Mm-hmm.
I'm going to try to work in this last question. It might take us a minute or two over our time limit. But it's a great question. Do youth age 14 and older in Iceland have the full legal decision-making ability for their health care and mental health, as do youth in Maine? And I'll clarify that in a minute. In Maine, parents report that these laws have impeded their ability to obtain health care that the youth may be refusing. In Maine, we protect minors in mental health and substance use. They can consent to treatment without their parents' knowledge, and you can understand why we would do that. But I can understand that those laws that provide some autonomy for that decision making and it isn't at age 14. It's at the age that the adolescent can have decision-making ability. In other words, we may have a 17-year-old who say, no, this individual is not in a position to do that. We might find a 12-year-old that has been living on their own. But I'm wondering, let's try to at least answer the question, and how is that question, and how is that situation handled in Iceland in terms of what a youth can do who maybe wants to confidentially get assistance for substance use treatment or for mental health treatment? Are their parents necessarily involved?
So I can maybe start and then Inka can jump in. So we don't really work with treatment. So in Iceland, when you're 18, you're an adult, and then you can start making your own decisions. Up until then, you're pretty much at the mercy of your parents. But so we don't really work with treatment. So treatment and recovery is just a whole science practice on its own. So when we work with prevention, we usually don't either work like directly with the kids, like it's with the community, it's with the social environment around the kids. So the parents, the members of the coalition, even in some countries, the faith community. So those are the groups that are going to be working in the coalition to implement the changes necessary. And those are the parties that we work with. But as for the impact of having that low age, having some say in treatment, I haven't seen that here in Iceland. I don't know if that's true, Inga.
Inga, go
I'm
ahead.
I'm not sure if they can make decisions or choose to accept or decline health services until they're until after they're adults, which is 18. But at 12, you can, I think, have a consultation with healthcare professionals, but without parents present under special circumstances, I think. But it is, but I'm not fully sure how it is. But 18 is the legal age.
I realize we're asking the prevention specialists treatment questions that have a legal component. So I'm not going to go further into that. We are out of time. We've answered most of the questions, I think, Richard. If there are any that we didn't answer, we will get them on the website. I am so appreciative of this discussion and of you participating from Iceland today. Nicole, thanks for arranging this, and thanks for the tremendous work you're doing around the world and in this country. We've had a couple hundred people help us, watching today, and I hope that this won't just be a one-off, that we can continue some of these discussions somehow, and we look forward to that. I'd love to come to your conference. Maybe some of you will be able to do that. So thank you again for your time. Thanks for all the participants. Hope to see you on, I think it's Friday, March 6th, when we talk about all things recovery from these cases where prevention's not been successful. But thanks. Have a great weekend. And thanks so much to our guest presenters today.
Thanks very much.